Hello and welcome everybody. It's great to see that so many of you have joined us this evening for our online talk on minimally invasive hip replacement surgery. I'm Katie, one of the members of the marketing team, and I'm delighted to be joined by Mr Senthil Kumar Velayudham, one of our consultant orthopaedic surgeons here at the Horder Centre who specialise in hip surgery. We have a great hour ahead of us, so before I hand over to Mr Velayudham and his presentation, I just want to remind you that this is a live recorded event and the recording will be emailed to you tomorrow. We won't be able to respond to raised hands directly, but do drop any questions that you have into the Q&A box for us to address during the segment later on. If you do not wish for your name to be included, there is a checkbox for you to tick before you submit your question. But once again, thank you all for joining us and please welcome Mr Velayudham.
Okay, good evening everyone and thank you all for joining us. Right, we have received some questions beforehand, so I'll try to incorporate these questions and answers in my presentation, but if you feel you need more information, please feel free to ask more questions. I will be more than happy to give the answer. Okay, so this is a picture of a hip joint where you can see that's a healthy hip joint, and the blue color is the cartilage which is lining the bone within the joint, and that's the capsule. So osteoarthritis is basically the cartilage wearing out. It could be due to various reasons. It could be just natural aging process, or it could be due to other problems like fractures or infections, whatever the reasons. So the cartilage wears out, and the bone underneath the cartilage is sometimes exposed. So that's a fundamental or the basic problem or pathology in the hip osteoarthritis. So if you look at the X-ray, this is how it looks. That's a normal looking hip joint. That's on the left side. You can see that's the socket margin, and that's the ball. And the space between the two is the cartilage, articular cartilage, joint cartilage. And that wears out, as you can see in the picture on the right side. Cartilage is completely worn out, no space between the ball and socket or the ball and socket joint, the hip joint. That's the fundamental pathology in the osteoarthritis of any joints in the hip here. You're seeing there are some other features of the osteoarthritis as well, but they are more of secondary features. But the primary problem is cartilage wearing out. So the hip joint is right there. That's where our hip joint is commonly. And the pain is commonly felt around this area. Pain can be felt either around the outer aspect of the hip or right in the groin or coming down the thigh. Rarely can be felt just in the knee. That's extremely rare. So the pain is a common presentation of hip osteoarthritis. And then stiffness. So some patients will have stiffness sensation, but not necessarily stopping them from doing things. But eventually it does end up stopping people doing things like, for example, putting the shoes on, socks on, or trimming the nails, etc. The restricted activities. So the gradual deterioration activities, the walking distance will reduce, and they'll be able, it'll become more painful, and so the less and less activities, other activities like cycling or playing sports, all those things will be restricted. Limping is again a feature of hip arthritis. This is as a result of the pain. The difference in leg length is very rare that one notices. Additional noise from the joints, like clicking sensation or clunking sensation, can happen when the arthritis is quite advanced. But these clicking noises can be because of other reasons as well. The main problems are the pain, stiffness, restriction of activities. How do we, before we go to the non-operative treatment options, how do we prevent it? The joint cartilage is a very specialized structure. Our body doesn't have the ability to reproduce it, regenerate it. A lot of research still going on, trying to regenerate this cartilage and artificially, and then put it back in the patients to see whether it helps the patient. We haven't made a significant advancement in that aspect yet. The best way to preserve the cartilage or improve the longevity of the joint is some form of regular exercises. Exercises helps to maintain the nutrition of the cartilage, helps to strengthen the muscles around the joints, and maintaining a healthy weight. All these things helps to slow down the wear process in the joint. The wear process is going to happen to all of us, unfortunately. All we can do is to try and slow it down and try and prevent injuries, etc. But that's, part of life, unavoidable sometimes. Other conditions like inflammatory conditions like rheumatoid arthritis or developmental problems, these are beyond our control. The things within our control are regular exercises, maintaining a good healthy weight. So once the osteoarthritis happens, what can we do? Or it's to try and keep the symptoms under control. Certainly at the early stages, the non-operative treatment options helps control the pain from osteoarthritis. Now, with the osteoarthritis, the pain can be either due to osteoarthritis itself or the primary symptom, or it could be other symptoms, secondary symptoms, I put it as, like the way it affects the muscles around the joint can also give sometimes pain. So these secondary symptoms can be very well addressed with non-operative treatment measures like the physiotherapy, etc. The painkillers help to control the pain. It doesn't cure the pain, and there is no one specific painkiller that suits everyone. So it's more of trial and error the patients have to do to find out which is ideal, which works for them the best, and then stick to that. Obviously, there is a limitation to every type of painkiller, and if one has to take large amount of regular painkillers and there is significant arthritis, probably continuing with painkillers alone is not a great option. Even if there is arthritis, doing exercises is important. Some of the patients do ask me in the clinic question, or can I continue doing exercises? I don't want to do a hip replacement now. Can I continue doing exercises? Is it going to wear it out more quickly? Answer is no. You do the exercises within the pain limits. And you might have to modify the exercises. Say, for example, the person is very keen on running. Continuing running will probably wear it out quicker because you're putting a huge amount of stress through the joint with every step during running. So that is not a good idea. So probably one has to modify the exercise, do more of low impact exercises. That helps to control the pain and also slow down the wear process. But some form of low impact regular exercise is good to control the pain, and the exercises within the pain limits will not wear out the cartilage quicker. So exercises is important, and it helps to maintain the strength of the muscles. It helps in two ways. One, the way the nerves are connected, it helps to control the pain to some extent. Second, you're not losing the muscle strength or the muscle bulk. So eventually when you have a joint replacement, you'll be able to recover better. If the exercise are not done, if the muscles are wasted and weak, then obviously it's going to take longer to recover after a joint replacement. Using support while walking, it's most patients don't like using it, but it does help increasing the walking distance. And I certainly recommend to the patients who tend to feel the giving way sensation, because it's again the prevention. You don't want to have the giving way sensation, have a fall, and something else goes wrong, going wrong. So using support does help. Hip injection. For some reason, the injections, like steroid injections, don't seem to work very well with the hips compared to other joints like knee or shoulder, foot and ankle. We don't know the reason exactly why. I do recommend this at the early stages, when there is mild arthritis, when there is evidence of inflammation, say, for example, on an MRI scan, then I think trying a hip injection is worth it because it does ease the pain, but the duration of pain relief is variable. Some patients, it can be a few weeks, some patients can be a few months. Very rarely I've seen patients having benefit, say, for a year or two after the steroid injection. Those are the patients who had only sort of probably very mild arthritis. They had a slight flare-up, injection eased the pain, and they did all the other right things like exercises, weight maintenance and everything. So they carried on for quite a few years. But commonly, the hip injection, steroid injection, pain relief doesn't last for more than a few months. And if it is advanced osteoarthritis, where the bone is rubbing on the bone, very stiff joint, very painful, my experience is that the patient usually come back after a few weeks saying, yeah, it was great for a few days or a couple of weeks, but the pain has come back again. And maintaining a healthy weight. So these are the non-operative treatment options that you can persevere with before considering surgical treatment options. The exercises or specific hip exercises, again, there isn't one sort of list of exercises for everyone because we all vary in terms of the strength, range of movements, etc. So it may be worth seeing a physiotherapist to get the joint assessed, and they can give you a program of exercises tailored to your needs, your strength, your strength and weakness, and etc. What are the operative treatment options? Now, when at the early stages, like early stage of osteoarthritis, we can sometimes consider what we call as a hip preservation procedures, like hip arthroscopy or realigning procedures. A hip arthroscopy is commonly considered when there is a condition called femoroacetabular impingement. If there is no arthritis, treating the femoroacetabular impingement has good success rate. When there is arthritis, treating the impingement problem doesn't give that much success in terms of pain relief and function, because once the osteoarthritis starts, it takes over the problems or the presentation, and the results of addressing the femoroacetabular impingement is not that good. But still, sometimes I consider it. The patient is very young, like in 20s or 30s, and if they've got good range of hip movements, then I do give the benefit of doubt to the patients and then offer them the hip arthroscopy. Eventually, the end stage is advanced arthritis, where the cartilage is completely worn out, affecting quality of your life, restricting activities, sleep is disturbed, and you're not able to enjoy your lifestyle. Then eventually, the patients will need some form of hip replacement. Could be either a minimal invasive hip replacement or resurfacing hip replacement. These are the sort of two broad types of hip replacement: minimal invasive total hip replacement or resurfacing hip replacement. So this is just a picture of hip arthroscopy. You can see on the right side, that's a socket ball. That's a bit of a bump there. That's called causes the hip impingement. And you can see I'm doing a hip arthroscopy there and shaving that part of the bone to avoid the impingement on the hip. This patient already has got mild arthritis, a very young patient. So I thought it'd be worth trying hip arthroscopy to delay or slow down the wear process and delay the hip replacement. It's sort of almost 8 years down the line, patient still doing fine, which is reasonably a good success. So coming to the hip replacement, these are the sort of two types of hip replacement that I mentioned earlier. One on the left, that's called the resurfacing hip replacement. And this is conventional total hip replacement. The percentage of patients who are suitable for resurfacing hip replacement is very, very, very small. Just to give you an example, I do more than about 500 hip replacement in a year, whereas I'll be doing probably about 10 resurfacing. Out of those will be, out of those procedures, only 10 will be resurfacing hip replacement. There are reasons, because the resurfacing hip replacement is currently done only under the age of 60 in men only at the moment. And they should have a good hip anatomy. So there's only a small proportion of patients who are suitable for resurfacing hip replacement. The reason being, the prosthesis is made of all metal, cobalt chrome alloy. So the wear particles released from this joint bearings can cause soft tissue reaction. And it unfortunately seems to be higher in women. Reasons are not very clear. Maybe it's because it's a smaller bearing surface, or maybe there is some genetic predisposition. So at the moment, we are restricting this to only men under the age of 55 or 60 who are very active and want to pursue high impact activities like running, or continue doing heavy manual work, or want to participate in high level competitive sports. And they should also have a good anatomy, hip anatomy. Otherwise, it can't be done. The results of the resurfacing in this age group is good or equal to total hip replacement. And there is some anecdotal experience, evidence that higher proportion of patients return to higher level of impact activities with the resurfacing hip replacement. So I do offer this to men who want to participate in a very high level sports activities or high level of impact activities. This is the metal-on-metal resurfacing hip replacement. And this is a new version that's just come out this year. It's made of ceramic on ceramic resurfacing. It's got only 3 to 5 years results, which looks very good, whereas this has got 20-year results. So this is done on a very limited basis, and it is not widely done. And I'm just going to start doing this, but it's only patients who ask for it because they want to continue high level of sports activities. They are very young, like they're in 30s, etc., and they're not suitable for this metal-metal resurfacing. Just for information, I'm not going to go into detail about this ceramic resurfacing at the moment. So coming to the main topic, which is minimal invasive hip replacement. So what is a minimal invasive hip replacement? It's, in my opinion, it's not just the size of the scar that makes a difference in the outcome of total hip replacement. Certainly surgical approach, which is minimal invasive approach, makes a difference in short term and also some effect to some extent long-term results. The fundamental is paying attention to details of soft tissues, not damaging the soft tissues, which I mean the muscles, major muscles, the ligaments, tendons, etc. That's key. Handling the soft tissues is important. So that's the key thing in the soft tissue management around the hip replacement. But that's only one part of it. I'll come to this anterior or posterior approach in a while. What are the 3 or more important things are restoring hip anatomy of the patient? It is basically assessing the patient's hip anatomy in all 3 planes, trying to restore it, restoring the soft tissue tension, and restoring the leg length. So that's very important. That's going to determine your long-term function. A good fixation of the prosthesis. So it has to be fixed very well so that either it is cemented or uncemented. Good fixation will again make sure they can last 20 years or 30 years or 40 years. And good process, when I say good processes with good track record, basically. So these are all important. So it's not just the minimally invasive approach that gives good to excellent outcome. It's all these four components which give good outcome. So the anterior, this is a sort of outline of the bones. That's a pelvis, and that's the hip joint there, and there's a femur. So it's basically a patient lying on the left side. So we are looking at the right hip, basically. The two good approaches to the hip at the moment are the anterior approach, where you go almost at the front of the hip, or minimally invasive posterior approach, where you go somewhere at the back of the hip there. The reason is why there is one at the back, one at the front, and one at the back. There is also approach through the middle or the side of the hip joint. This damages the main muscle of the hip, called the gluteus medius, which is very important for a good function of the hip. The anterior approach and the minimally invasive posterior approach both avoids the muscle, avoids the damage to the muscle. That's the key thing. Theoretically, anterior approach goes between the planes of the muscles, but there is a lot of evidence that in spite of that, it does damage some soft tissues. Again, the posterior approach, you don't damage big muscles. You take the capsule, you have to take down the capsule on both approach. You have to cut the capsule, open it, and then you repair it back anatomically once you restore the patient's hip anatomy. It is well known that both these approaches give excellent outcome, equally excellent outcome at 6 months. A small proportion of the patients, maybe say 20% or less than that, may feel a bit better at 6 weeks and 3 months after anterior approach compared to posterior approach. But 3 to 6 months, there is no difference between the two approaches. And I choose the minimally invasive posterior approach because it is more safer, in my opinion. And my results are good. So this is what I do, and I stick to this. But I can do the anterior approach as well if necessary, but I prefer this one. So knowing what I know, if I need a hip replacement, I need to go to a surgeon who does a hip replacement. If we can do both approaches, and he'll say, you know, which one you would like to choose, this is what I would like to choose. That's my personal preference. So bottom line is, there is no big difference between the outcome between the anterior approach and the minimally invasive posterior approach at 3 to 6 months. Even in the patients who feel better at 6 weeks, they feel similar to the other group at 3 to 6 months. So as again mentioned before, the key components are restoring the hip anatomy, good fixation, good track record of the prosthesis. These are the key things. And a very good soft tissue handling, making sure that you don't damage any muscles and you repair the capsules and ligaments as anatomically as possible. Now, what's the role of the computer-assisted surgery? It's evolving. You know, commonly patients say, oh, the science has advanced so much. Why there are still so many unanswered questions with the human beings? Well, that's biology. There are a lot of unanswered questions. Again, how to assess individual patients' hip anatomy, alignment of the leg. What happens if one is slightly changed? How does it affect the rest of the body, like the knee or the ankle? We don't know. We are still studying them. We still evaluating these things and studying these things. So my opinion, we don't know all the information about one patient's hip, or we don't have the methods to accurately know the exact anatomy of each patient how it influences the spine, knee, and etc. At the moment, to give those information to the computer so that the computer gives back with more information and say, this is how you do it, and that'll give the perfect anatomy for the patient. So we are not at the stage, but it's an evolving surgery. At the moment, with the hips, the computer-assisted surgery seemed to help the surgeons with the leg length restoration. So if I feel leg length restoration is going to be a challenge with any particular patient, I will probably consider computer-assisted surgery. And this is in patients who have sort of complex hip problems or a complex spine problem, which is affecting the position of the hip. Those kind of patients where I might consider it. But still, it's evolving. There is no definitive evidence that computer-assisted surgery helps surgeons who do high volume. The numbers I mentioned earlier, one of the high volume surgeons. So it's well known that in high volume surgeons, it doesn't make a huge difference. Whereas surgeons who do less number of operations, probably it might make a difference. Say less means less than 100 or so, it might make a difference. The fixation techniques, I mentioned that we need the process needs to be fixed well. So, so this picture is slightly already. So these are the 4 components commonly that's used in the hip replacement. So that's the acetabular component, or called the shell, and this is always made of titanium. And this is an uncemented component because it's got a rough surface and tight fit into the socket. The bone grows into it, gives you the primary fixation. So once we place the socket, we place the liner inside the socket. So you can say basically it acts like a cartilage, you can say. And that's made of very high quality plastic. This has been the game changer in the last 20 years or 30 years, kind of plastic that we managed to, or not only as a scientist managed to derive, and then because they are very hard wearing surfaces. So 20 years ago or 30 years ago, we were talking about 10-year results. And the patients under the age of 60 were told, please go away, come back when you're 70, or above 60 at least, so that your hip replacement will last 10 years. But this has been a game changer, and now we are seeing the hip replacement lasting 20 years, 30 years, even longer than that. So that's a liner that goes in the socket. And that's a stem, or the femoral component, that goes in the femur, like this. And that's made of titanium. Again, the bone will grow into the prosthesis. And that's the ball which is fitted onto the femoral stem. And that's reduced. Once you reduce the hip, and that's what you look like. So that's a socket there. The space that you don't see, this in between the ball and the socket, is the high quality plastic, and the femoral head component, or the ball, and then the stem which goes down the femur. So that's uncemented hip replacement. Pretty much all the surgeons in UK, most of them use uncemented acetabular component, or the socket. When it comes to stem, either it can be uncemented or cemented, where the glue is used to fix the prosthesis. On the acetabular side, pretty much as I said, most surgeons use the uncemented acetabular component. On the femur side, there is no difference in the results between cemented component or uncemented component at 20 years. They both work very well on the femur side. So commonly the surgeon will decide the type of prosthesis based on the patient's anatomy. That's what I did. I look at the patient's anatomy, the quality of the bone, the functional demands, etc. And then I decide which will give them the best result outcome for a long term. And then you choose the prosthesis. So you have uncemented socket fixation, uncemented femur fixation. Here, uncemented socket, and that's a cemented pin. Okay. As I said, on the femur side, they both work very well, equally good. Whichever technique we use, one has to make sure that it's got a good fixation so that the bone bonds very well, or there is a good interdigitation in the cemented so that they can last 20 plus years comfortably. So the minimal invasive hip replacement, again, why this is it's become sort of most we think more successful in the last, I can say, maybe 20 years or so. It's not just the surgical technique that evolved. The other aspects of management of the patient also evolved with this minimal invasive hip replacement approach. So preparation of the patient, things like helping the patients to do more exercises to strengthen muscles, get their health better, pain management around the time of surgery, anesthetic techniques which has evolved so that they wear off the anesthesia wears off after, say, 3-4 hours after surgery, so that they can get up and about, walking with good control of the leg and good physio nursing input. All these things made a huge difference in the recovery after hip replacement in younger and active patients. But what we noticed was the rippling effect of this approach improved the recovery even in much older patients with more medical problems, etc. Even they were doing well quickly after the surgery. So it's a whole approach to the patient care, which has resulted in good, excellent recovery, early recovery. It's not just a surgical approach. So that's the whole team approach, which has evolved over the last 20 years. So how, as a patient, you can make sure that you get the best out of it? So the important things are it's important to make sure that it is advanced arthritis and you have run out of all the non-operative treatment options and you've decided to go ahead with the hip replacement. Try and read about the procedure and understand the post-operative recovery. So if you understand the procedure and the recovery, then it helps the patient to navigate through the process. It's like knowing a route. If you know the route how to go to London already, then it's much easier to navigate. If you don't, just get in the car and drive without navigation or not having seen the map, one is going to struggle. So very similar to that. Of course, it is not possible to, as patients, prepare for every surgery. But common operations like total hip replacements, they're pretty well established now. The care is well established. So there is a lot of information available on our Horder website, and the patients are given the information. So knowing the procedure, understanding the post-operative recovery roughly helps you to navigate through the journey quite comfortably. Optimize the general health. That's very, very key. So healthy diet, exercises within the pain limits. I've mentioned a lot about the exercises, the importance of it, and get some professional help if necessary. This will help to recover better after the hip replacement. Optimize the underlying medical problem. This is very, very crucial. Like making sure the blood pressure is well under control, making sure the diabetes is well under control. It's extremely important. If the diabetes is not well controlled, then the chance of infection is high. So that's very, very important to make sure that you have a good long-term control of diabetes. If you had a history of low hemoglobin in the past, then might be better to get it checked again, see whether anything needs to be done or medicines taken to improve your hemoglobin level. These are all important. And try and prevent any infection just before the surgery, because commonly that's one of the common reasons I noticed in our practice where the surgery is getting delayed, because a few days before the surgery, patients develop some chest infection or scratch the skin and the skin got infected, etc., and that delays the surgery. And if you carry any infection before the surgery, the chance of infection after surgery increases. So we are all very careful to avoid this problem. Stopping smoking it will help significantly. It affects the wound healing, smoking. It affects the chest, so the patients are more prone for chest infection. And minimize the alcohol intake. That will definitely help the better protein synthesis in your body, which is very important after surgery to heal better and fight any infection if you were to develop any. So these are all important things you can do before surgery to get the best outcome afterwards and also minimize the complications. Okay, preparation of the home is key. Try and avoid hazards. You could practice at home with the crutches and see how you can get around, or from your bedroom to the toilet, to the hall, kitchen, and where you can have trip hazards, how can you avoid that. It's a good practice. And so that's accessibility, making sure that you can access the house where you are, the parts of the house where you have to after the surgery. It's quite useful. Plan your meals and shopping, etc. Who's going to help you at home or outside, shopping and extra, or trips to the hospital. Have some plan in place that will help you to recover smoothly. You won't be stressed, even under pressure afterwards. And maybe you can prepare some set targets on goals to achieve post-surgery. For example, I'll walk from here to the gate or outside on the street, or do these exercises within certain days. It doesn't mean that you have to achieve them, but having some sort of goal helps you to work towards it and achieve it based on the information available on the given by the hospitals. So that'll be a good one to do. So surgery is done now, and how do we make sure that you recover better? So adequate painkillers is important. When the patients are under influence of anesthesia, when their legs are numb and things like that, or when the pain starts building up, they feel, oh, I don't need any painkillers, it'll be fine, I'm fine. And then suddenly when this anesthetic effects wears off, the pain shoots up. So taking adequate painkillers at intervals, the early stage is crucial so that you can do the exercises. You have to take adequate fluids and food to have enough strength to do the exercises. Fluid is also important because you don't want to drop in blood pressure when you stand up after surgery. So that's important. And start the gentle exercises as soon as possible while you're in bed. As the legs start recovering, start doing the exercises. The physiotherapist will be there, staff will be there to help you with that. The earlier you start doing exercises, the earlier you start mobilizing, the lesser the pain will be and the quicker the recovery will be. There is also downside of these two components. One should also try to avoid overdoing it at the early stages, because that also can be detrimental in terms of increasing the pain and affecting the outcome. So within the guidance, with the advices given by the physios and outpatient, the nursing staff, you should do the exercises as early as possible, but in a controlled manner. Post-operative, one of the things I insist or emphasize is little and often. That's what I tell my patients. You do small bursts of exercises, but often in a day. Frequent exercises, like every 1 hour, 2 hours, little exercise is better than doing 2 big sessions of exercises in a day. Also, please remember that the recovery varies from person to person. I'll show you a graph in a few minutes. Most of the patients have a sort of steady progress and recovery. Some patients will make a very rapid progress. And if, for example, they'll come on in a week or two, they say, oh, I've thrown away my crutches, I'm driving now. Is it okay? Some patients might be a bit slow to start with, but eventually they'll catch up. In my opinion, if the surgery is done well, the patient has prepared themselves well, following the advice of the physiotherapy, even if the rate of recovery varies from person to person, the final outcome at 3 to 6 months will be equally good. And also recommend that use the support in the first few weeks, at least a couple of weeks when the muscles are recovering, so that they get stronger, and then you can wean off the support. And it'll be, this is just to avoid stumbles and small accidents at the early stages that can lead to problems like fractures, etc. So avoiding risk as well. So basically, this is just to give you an example. This is a hip which has been done a few years ago, and that's just done recently. You can see the process. There is a little bit of gap there. Basically, what is happening is over the period, it all gets filled up with the new bone. So the first, being careful in the first few weeks is to allow the bone to grow into the prosthesis. So when we put the prosthesis in, that's a primary stability, strongly fixed. But the secondary stability, which is important for the prosthesis to last 30 or 40 years or at least 20 years, is the bone bonding into the prosthesis. So you're protecting the first few weeks, what's happening between the prosthesis and the bone. So commonly allow the patients to start low impact exercises anywhere between sort of 2 to 6 weeks, like a gentle exercise on static bike with low resistance, gentle, more slow speed. It's for smooth movements of the joint. Water-based exercises once the wound is clean, dry, and scar looks fine. So probably around 3 weeks more. Even before you can, if you have got a waterproof dressings, patients do that under the supervision of the physiotherapist. And it helps to recover better. And then around 6 weeks mark, you can start doing more low impact exercises, start gym-based exercises, controlled exercises, Pilates, yoga type exercises can start around that time. Outdoor cycling, I generally advise the patient to wait at least about 3 months. Again, this is by 3 months, the bone has bonded to the prosthesis quite well, and then you can start pushing the limits. So that's why I like the sort of 6 to 12 weeks where you gradually introduce all these sort of activities, golf, tennis, etc. I advise the patients to avoid the impact exercises like jumping, running on at least for 6 months, because I want the process to be solidly bound with the bone. And so the repetitive high impact exercises won't lead to loosening. This is all to improve your long-term outcome. That's in 20 years and 30 years, etc. So this is this is not accurate graph. Forget the numbers here, the percentage. It's just the time period on the graph. So most of the patients are here on orange line. Okay, there will be a small proportion of patients who do very rapid recovery and then they plateau, and some will be slow to start with, but eventually will again do well. So most here, some here, and some here. It doesn't matter, as long as they are making progress. Eventually, most patients, more than 90-95% of the patients, will reach a good to excellent outcome. It is important to continue doing exercises in long term, like down the, after 6 months, after 1 year. Is it okay to stop the exercises? I'm doing other things like, I'm walking long distances. I'm doing a lot of gardening. I'm active throughout the day, but I'm not doing exercise. Is it okay? Not really. My advice to all patients is that it has to be a combination of few exercises. Cardiovascular, so like walking, doing a lot of gardening, that's fine. Some specific targeted exercises for the muscles, like gym training and all of this is very important. And some stretches like yoga, Pilates type exercises. It has to be a combination of this. This helps to keep the muscles in a good shape. Please remember that the joint has been replaced, but the muscles are the same. The muscles and tendons are also prone for a bit of wear and tear. So best way to keep them in good shape is by doing exercises. There is no evidence that exercises reduce the longevity of the prosthesis. So it does mean that if you keep doing cycling or if you keep walking long distance, you'll wear it quicker. So should you be doing less so that it lasts 40 years rather than 30 years? There is no real evidence like that. So, and we are pretty confident about the current materials that's available. So we let the patients do as much as walking, as much as cycling, swimming or other sports activities as much as they want to do. Running, as I said, after 6 to 9 months, they can start running. Depending upon how they feel, they can continue running. Safe to avoid periprosthetic fractures, because if you were to have any fractures around the prosthesis, then it might need revision. So that's where you have to be careful. Avoid infection. So even if down the line, years down the line, if you were to develop any infection, treat them promptly. Don't leave it thinking, it will settle down, because it's very, very rare, but the infection from other parts of the body can travel to the hip joint even a few years down the line, like 10, 20 years after the replacement. So any infection, treat them promptly. All these things will help you to enjoy the hip replacement in a long term. Thank you.
Thank you very much, Mr. Velayudham, for running us through some very important points when it comes to minimising the risk and maximising the benefits of minimally invasive hip replacement surgery. I know you mentioned the questions. We did receive a few in advance, which you have been able to address a fair amount. There are some yet to be covered, so we'll move on to those outstanding. Along with, I will just check any that have come through during the session as well. I'm just conscious of time. So did you want to start with a few that you
Sure. So one of the questions was patient with scoliosis and left knee arthritis, advanced arthritis in the right hip, how best to manage. So the things that you have to assess is how much the hip arthritis affecting your activity levels. Whether you're maintaining good level of physical activities in spite of advanced osteoarthritis. If you are, with the help of physiotherapy and painkillers, you can continue with non-operative measures. But if it is affecting your physical activity levels, having to take more stronger painkillers on a regular basis, then they have their own side effects as well. Like, for example, if you do less and less walking, less and less exercise, you're deconditioned to some extent. And if you're taking regular anti-inflammatories like ibuprofen or naproxen on a regular basis for a longer period, they have side effects as well. Then you have to assess yourself how much it's affecting your quality of life, and then you have to make a decision after having a professional chat with a surgeon as to whether you should consider surgery. So yes, you can continue with non-operative treatment like physiotherapy and painkillers as long as you would like to, you want to, provided your symptoms are not affecting quality of your life or physical activities. I think I covered the question about the femoroasteroidal impingement and the hip arthritis. When there is hip arthritis, I think the question also says the age is 60 plus. So commonly that means addressing the hip impingement is not going to help the patient. So it's going to be eventually a total hip replacement. But again, one can continue with non-operative treatment measures as long as they can maintain good level of physical activities and they enjoy good quality of life and able to control the symptoms well. So you can continue with non-operative treatment. Probably 60 plus, I wouldn't be considering hip arthroscopy because the results are not good. There's no point in doing a major operation and then 2 years down the line, you come back for a hip replacement. It's not really worth it. That's how I look at it. Minimally invasive hip replacement can be done in patients with heart conditions? Yes, of course, because the minimally invasive hip replacement, as I said, all those things, the whole approach has improved the outcome after the hip replacement, how quickly the patients recover, etc. The patients who don't have any medical problems, very active, probably will do better quicker, say few days to a few weeks quicker than patients with lots of medical problems. But still, our experience is that they all recover well. The average length stay at the Horder Centre or in the hospitals in the region where I work, like Tunbridge Wells or my colleagues at the Hastings, etc. It's like 1.5 days to 2 days. That's average length of stay. That includes all range of patients. So yes, minimally invasive hip replacement is what most surgeons will do for patients with medical conditions as well. It's better to have both hips done at the same time or staged. There are a few criteria I have. If the patient is healthy, no other major medical problems, and both hips are equally bad, then yes, I'll offer both hip replacements. If the patients have got significant medical problems, or say more than a couple of medical problems, then probably they are a higher risk of complications. So it's basically avoiding the risks. If one operation, which is going to take 4 or 5 hours, and it has to be done in the best interest of the patient, we do it in spite of the medical problems. We have a discussion with the patient, make sure that they understand, and we do the surgery. But when it can be avoided, for example, 2 hip replacements, one at a time can be done. So is it worth doing that in a patient with many medical problems, both hip replacement at the same time, and increasing the risk, or better to do it at stage so that they have lesser chance of complications? It's all balancing the benefits and the risks and making a decision. Answer is, it entirely depends upon how bad the hips are, whether both needs to be done at the same time, and whether the patient is in a good health to have both hips done at the same time. If the answer is yes, can be done. General or spinal anesthesia, pretty much 99% of the hip replacements are done under spinal anesthesia, plus some sedation, which can be very mild or none or deep sedation. But the main anesthesia is spinal anesthesia. There are some reasons for that. It reduces the blood loss during surgery, which is good for the patients and surgeons. It has got some anecdotal evidence that it reduces the risk of deep vein thrombosis after surgery. And it reduces the need for strong medications like morphine. So the patients feel a lot better after surgery. They're comfortable. It's nothing more pleasing than to see a patient walking 3 hours after the surgery, after having had their meal and a nap orders. It's very clear I'm not having any side effects of general anesthesia like giddiness or sickness and etc. So it's got huge advantage. That's why the anesthetists and surgeons like patients having spinal anesthesia. But there are some situations where spinal anesthesia is not advisable, that the anesthetist will decide, in which case general anesthesia can be safely given. And some patients don't like the idea of spinal anesthesia. They've had some bad experiences, etc. In those patients, the anesthetist will have a discussion explaining the pros and cons of each, and then make an informed decision. The risk of nerve damage is extremely rare after primary hip replacement, but it is known. We take all precautions. We try to identify the nerves, protect it, do the hip replacement. That's extremely rare. Dual mobility hip replacement. It's a lot is being discussed about the dual mobility hip replacement. There are a lot of technical things. It's very difficult to explain on this webinar, but it is useful in reducing the risk of dislocation in patients with certain problems, like spine problems, where they've got a bad scoliosis, curvature, stiff spine, and they've got a very lax joints, because some patients have very lax joints. And they've got some tendency to dislocate, etc. Those sort of situations, yes, the dual mobility seems to be helpful, but there is no evidence that on a standard total hip replacement, in most of the patients, it makes any difference. So I carefully select the patients for the dual mobility, or select the dual mobility where it's necessary for the, but if I feel, yes, it'll benefit the patient, I will do it. And a lot of revision surgery for instability, I use the dual mobility. It's quite useful. The reason why it's not widely done, in spite of the theoretical aspects, we don't know the unknown long-term complications with the dual mobility. It's being closely observed. So we have to wait for the long-term results to see whether it is definitely better than conventional total hip replacement, which is a gold standard at the moment. I mentioned about the computer-assisted surgery. Resurfacing hip replacement, we briefly touched. Having it reversed at 18 years, the resurfacing hip replacement, if there is a problem with the resurfacing, yes, it needs revision. The common problems are either loosening, like any other hip replacement, or the adverse reaction to metal debris, which is extremely rare, with a couple of prostheses which are still being used widely throughout the world, or infection or fractures, which can be late problems, then yes, it can be revised, but it depends upon the indication why the hip is being revised. If it needs revision, yes, it can be safely revised, and the patient's results are good after revision of the hip replacement. I hope I have answered all the questions, but if you have any more questions, please feel free to ask.
Fantastic. I'm conscious of time, and I do have to say sorry that we started late this evening. We've had a couple of technical issues. We probably have room for, I'd say, one more or two that have come through just while you're speaking. You may have mentioned this already. Is dual mobility hip replacement something you've mentioned that with the you've also mentioned this. How soon can you go swimming?
So
yeah.
So dual mobility, I've already mentioned. I do use the dual mobility in selected patients with mainly with the spinal problems, hyperlax joints, or if I'm going to revise the hip replacement because of the hip instability issues, I use a dual mobility hip replacement. How soon after the operation can you go swimming? I mean, as I said, you can get into the water under guidance or supervision even within a couple of days, 3 days after the hip replacement. A lot of rehabilitation places where they do that, but on your own, probably I would say 3 weeks, where you safely, if you can get in out of water, that's very important. That's make sure that you're safe. You can use the crutches safely, walking to the pool and all. You don't want to slip and fall. And first, start just walking up and down the pool. And if it feels comfortable, you can start swimming gradually. And the breaststrokes are fine. It doesn't increase the risk of dislocation, so that's fine. So I would say around 3 weeks mark average, you can get into the pool and then see how you feel. Start just exercises first, walking up and down the pool, and then swim and see how you feel. How soon after the hip replacement can knee replacement take place? Usually, I would say around 6 weeks, safer. Anytime after 6 weeks, it should be fine. Putting the spike the
6 weeks or 6 months.
6 weeks. It should be fine if it's urgent. Yeah, if it's urgent, 6 weeks is safer to wait before the knee replacement. Does putting a spike down the femur affect bone marrow? Not really. There isn't. By the time we reached the adult stage, the bone marrow in the femur doesn't produce much blood cells or white blood cells. And the bone marrow is only in the top part of the femur. Down the canal, there isn't much there. It's all more fatty marrow. No, it doesn't affect the generate blood cells, ability to generate blood cells at all. So it's pretty safe. Do you recommend correcting natural leg length disc difference during hip replacement? If a patient has got natural leg length difference because of whatever the growth issues or whatever it is, you have a few millimeters of play with the hip. But if you shorten it beyond a few millimeters, then it increases the instability of the joint. If you stretch it beyond a few millimeters, when I say a few millimeters, say 4 to 5 millimeters, that's what I would be comfortable with. Beyond that, if you try to stretch it, it might affect the soft tissues, like you may feel more soft tissue discomfort. So one has to be careful. So I don't promise the patient that I will match the leg length if the problem is not because of the hip. If the problem is because of the hip, yes, then it can be matched.
That's great. Thank you very much for just squeezing those last few minute questions in. And thank you for those who have managed to stay on a little bit this evening. Thank you for taking the time to join us this evening. If you did want to book a consultation with Mr Velayudham here at the Horder Centre, please do get in touch with the contacts that have been sitting on the screen there, so telephone and email. And just to let you know that when you do receive the recording tomorrow, you'll get a survey for you to complete as well, just to give your feedback on how today went. But once again, thank you very much for taking the time to join us. Thank you, Mr Velayudham, and enjoy the rest of your evening.